Good morning, everyone. Just to clarify, the RIN trial is an international collaboration effort. I think this is why we succeeded. The first thing is thank you for giving us the opportunity. You are discussing a very important subject, and we felt it was important to share with you what we do at WHO because it may help to frame some of your conversations. So I will start by talking about a program that has more than 30-year history. Since 1974, WHO and the member states have been working on trying to establish immunization programs that provide a highest quality of vaccine delivery, that uses vaccines that are of good quality, and that achieve the highest impact with the lower cost possible. And that is important to bear in mind. The second thing is that we, as an immunization community, have clear goals that were set at the beginning of the decade, and we call those goals the Decade of Vaccines goals, and they are reflected in what we call the Global Vaccine Action Plan. And they are also very important because it helps to understand where are we trying to go as a community. So you can see there are 5 goals related to polio, increasing coverage in every district, exceeding the Millennium Development Goals in terms of reducing child mortality, achieving regional elimination goals, and also introducing new vaccines. That is part of the complexity and the important issues to consider. Again, we in the Department of Immunization, Vaccines and Development and in WHO are trying to help countries achieve those goals by providing the support that is required so the countries can deliver high-quality immunization services, and we do strive to do that as part of an integrated platform of delivery. And we are also very focused on ensuring that we don't only focus, like initially, in infants, but we do work throughout the lifespan. This graph is to remind me that I should tell you that besides all the complexities and all the health economics and broader impact of vaccination programs, the EPI of today is not the EPI of the 1970s. As you can see, not only the global population has almost doubled, but also the number of antigens, injections, contacts that are used in every country worldwide has multiplied. So if we just have a narrow vision of the immunization program as a standalone intervention, the complexity of the program itself is quite big. But we are very happy because we work on immunizations. We work on programs that reach 116 million children, infants, every year. And that is a huge achievement. And we always talk about what else can we do, but we should not forget where we are today. And people always talk about what they are doing for tomorrow to help, but we come from a generation that achieved what everybody thought it was impossible. When the program started, less than 20% of the children in the planet were benefiting from these life-saving vaccines. Today, to achieve our goal of 90% coverage, we need to vaccinate additional 6 million children. That seems like a lot, but compared to what we achieved, we are convinced we can do that before the end of this decade. The other piece of work that we do in WHO is to try to maintain, and this relates to these conversations of policymakers, because there are policymakers at all levels. The colleague was talking about the policymakers in the sub-district in KwaZulu-Natal, but we are also focusing on maintaining the importance of the immunization as a good health intervention tool at the highest forum, that is the World Health Assembly. Every year, we present the reports and the progress of the immunization program. Every year, we hear the member states complaining or congratulating the Secretariat and those in the community for the achievements. And that process is critical. Now let's move into the immunization research. So in WHO, in the department, we have 2 groups, the EPI group, the Expanded Program on Immunization group. They are like the downstream guys. They are, once the policies are written, they have to work with the countries to help implement these policies. And there is the other group where Raymond and I work, that is the Initiative for Vaccine Research. So we are the ones who are working on vaccines and immunization research. We divide our work in two main areas. One is on the vaccines that are already available and licensed, and the other is on the vaccines that are under development. And among the work that we do on the vaccines that are licensed, we focus in three areas. The first is on research to minimize the barriers and improve the coverage of existing vaccines. For example, why children in certain countries do not get vaccinated. One of the recent pieces of work we did was to work on assessing missed opportunities for vaccination, meaning children who are already in contact with health services, but who are not screened or who are rejected due to false contraindications when they come in contact with the health service. We also work on research to improve monitoring of immunization programs. For example, we have discussions about how best at the service delivery you can record the vaccination status of a child and monitor it over time. And finally, and very important for this discussion, we look on research to assess and improve the impact of immunization programs, whether the delivery strategies that are used are the most effective, whether we are implementing the strategies in an integrated way that maximize the benefits of the immunization program, or whether the cost of the vaccines that we are using or the assumptions we are using to make our decisions are the most appropriate and the best informed. In between the products that are already licensed and the products that are under development, there is a very important branch that is how to prepare when you have products that are quite advanced, how to prepare the evidence that will inform the policy that will lead to recommendations on the use of these products once licensed. And lastly, we work on more upstream work that is regarding about, first, what are the attributes of the products that are being developed. So we work in developing target product profiles that hopefully will help those in industry understand what is required from the products from the public health perspective. We also work in providing the necessary encouragement and helping to develop the guidance to assess vaccines at early stage of development, particularly those vaccines who are not perceived as highly valuable by mainstream research and industry. Somebody calls them the orphan vaccines. And finally, we work to encourage initiation of research for vaccines for diseases and pathogens for which there is a potential, but the community as a whole has not identified this as a priority. One important tool in our work on implementation research is our immunization vaccines related implementation research advisory committee. Luckily, we have an acronym, IVIR-AC. And this committee is quite critical because this is the committee where we discuss whether or not the methods for evaluation of the efficacy, effectiveness, cost-effectiveness, incremental cost-effectiveness, the models are appropriate, are state-of-the-art. And we are very much confronted every day with people who have done models and who have worked on burden of disease estimates or impact evaluations, and we like them to become mainstream or even the WHO official estimates. So this is the committee who looks into that and critically focus on the methods and on the evidence that was used to inform those models, those analyses. We also focus in this committee in looking at this implementation research work that I mentioned on improving access to vaccines, expanding the coverage, addressing the barriers, and we have a research agenda that is evaluated regularly with the help of the committee members to ensure that we keep moving and that we keep encouraging the necessary research. And finally, we have issues on a special subjects. So sometimes there is a topic, let's say, maternal immunization with influenza vaccines that is addressed and discussed, not from the perspective of the vaccine, but from the perspective of whether the methods that are used to make the argument for the use of this intervention are the state-of-the-art ones, or if there are any issues that should be addressed. In our free time, we also work on what is called the Blueprint for Research and Development. You all learned that we all as a community learned a lot about what kind of research and what needs to be done to prepare, especially to address the issues related to diseases that can lead to public health emergencies of international concern. So we have developed, and this is almost an organization-wide effort. We have developed what is called the Blueprint and the Plan of Action for Research and Development. This is a global strategy, but also is a convening mechanism. It's an effort to articulate all the potential work. It's an effort to identify gaps. It's an effort to become more transparent, to force us in the community to have the discussions about the study designs or the ways to do things before we are in the middle of the outbreak and not during the outbreak. So to achieve that, the blueprint has three main areas of work. The first one is improving the coordination and fostering an enabling environment. We have already initiated collaborations with several key partners in the research and development area to establish a mechanism for global coordination of research related to these pathogens. We have also started to prepare mapping, so who are the researchers, who is doing that, who is funding that. That will be soon put on the web and available. And we are trying to identify what is the best ways to communicate what is happening in this field in terms of research and development. And we are focusing on vaccines, therapeutics, and laboratory tests. Second, we are trying to accelerate the research and development process. How? We are first assessing through a transparent mechanism what are the priority pathogens. And the first list of these pathogens was published in December of last year. This year, we are going to publish again the methods and the revised list of priority pathogens. And I'm talking about diseases like Zika, Nipah, Crimean Congo, fever, Ebola, etc. We are also, once the pathogens are identified as priority, of course, one has to sit down with the relevant experts to see where are the products, the candidate vaccines, the candidate therapeutics in terms of research and development. Where are we in the R&D roadmaps, and what are the gaps, and how can these gaps be addressed? We have developed the research and development maps for MERS-CoV, and we are using that as a framework to develop other R&D plans. We are also working quite actively on the regulatory pathways and on the ethical approaches. Why? Because we have learned that what you do in normal times is not the same that you could do during outbreaks. And we are all in agreement that we should maintain the highest levels and the highest standards, but one has to be realistic and one has to adjust to the situations. So we are promoting a dialogue between ethicists and regulators and clinical trialists to ensure that next time we have a better conversation ongoing. Finally, we are developing new norms and standards adapted to the epidemic context. For example, we have a work on developing trial designs that are more appropriate for epidemic diseases that have sporadic outbreaks or fewer cases than you are normally organized. Because if you are not prepared, or you prepare your trial for a large outbreak and it never comes, you will be always unable to truly assess efficacy and effectiveness of these products. Finally, we are developing tools for collaboration. It means we are promoting a transparent mechanism for collaboration between researchers in developing countries and ministries of health in developing countries with other international researchers in terms of how the memorandum of understanding should be prepared. What are the agreements for material transfer of samples? What are the agreements for data sharing? So that we have generic formats that are available to all and that people can use as guidance during negotiations. There is a lot of people, and that's good seeing, there is a lot of initiatives working now on trying to accelerate the work for pathogens. But we feel at WHO that none of these initiatives have a global outlook. So we are trying to connect all these initiatives together through the global coordinating mechanisms and all our specific technical efforts to ensure that we don't have a fragmented approach, but a global one. Now moving into that, the reason why we do research is because we want to improve coverage. And to improve coverage, one of the tools we use is to have well-informed policies, to have policies that are based on the evidence. And our forum for discussing policies at WHO is the Strategic Advisory Group of Experts that is our main advisory committee for immunizations. This is just a schematic of how this happened. I'm not going to walk through all the bubbles, but just to tell you that there are different levels of policy making. Once the evidence is reviewed and a policy is issued, there are interactions with regional advisory committees to discuss how these recommendations translate into implementation in the ground. There are discussions at country level on how the implementation should be operationalized, what resources are required, et cetera, et cetera. All our positions are presented in what we call the vaccines position papers, and they clearly are designed to inform country-level decision-making. You have talked about complex issues. Yesterday we saw even questions on how to make decisions. I'm going to talk about what SAGE uses as information to make policy currently. Of course, we do grading of evidence. Of course, the evidence is considered in accordance to the risk of bias of the studies that contributed, et cetera, et cetera. But I just wanted to highlight the main elements of evidence that are required and are considered at SAGE when we look at the policies for any given vaccine. So we look at the epidemiology and the clinical profile of the disease, the benefits and harms options, the values pertaining to the importance of the desirable or undesirable effects, equity considerations, the feasibility and the resource implications, the social values and preferences, the health system opportunities, such as those of integration that I mentioned earlier, and the interaction with other existing interventions and control strategies. For example, HPV and screening, or rotavirus vaccine and oral rehydration solutions, et cetera, et cetera. This graph, these bubbles, is to show that when we are at SAGE, we look at it from different perspectives. I just have examples of the kinds of information are considered to inform policy, because I think that it is important to keep in mind that also we would like to have complex systems for decision making. In reality, at SAGE, at regional tax, and at country level, the approaches sometimes are more simplistic. Since I am not a health economist, I could say that. We focus on where are the unvaccinated. We focus on which are the countries with most of the unvaccinated live. And in this occasion, you can see that only 10 countries accumulate most of the children unvaccinated. So, of course, that has implications for what we do at global and regional level. We also look at the coverage in each individual country over time at the trends. And yesterday, somebody was talking about Ebola. So if you look at the 3 Ebola-affected countries here, Ebola didn't seem to affect the coverage in Sierra Leone. It has some impact in Liberia and some impact in Guinea. But you can see that both Liberia and Guinea were not performing well even before Ebola. I mentioned integration, so we look at the coverage of vaccines across the continuum of care. And in this case, it's important and it's a responsibility for us, because a part of neonatal tetanus protection and vaccines, most of the other interventions are well below 90%. We also consider the overall impact of vaccines in mortality. And in this graph, you can see that the gray area, that is the non-vaccine preventable disease area, has decreased, but not in a substantial way compared to the decreases on those areas that are related to vaccine preventable diseases. So we look also at the overall impact of the program on childhood mortality. We consider inequity, and I just showed this map from the Democratic Republic of Congo, where unfortunately the areas in yellow and red have increased over the years. You have heard in the news, especially in the north, that there are difficulties with security, etc. So these are considerations that are not in the equations so far, but that are important and drives decisions on immunization program. We also look at the new paradigm, the new situation. For example, now we have 21 million people who are estimated to be refugees, who requires decisions. So our normal model of decision-making for countries and states have to be reconsidered also to cater for these people that are perhaps some of the most vulnerable today. Umesh is going to talk about ROTA, so I will not make any advertisement about ROTA. but rather that I talk about meningitis A, and so people are talking about the impact. We use many meters to assess the impact of vaccination, and the fact that here there are 6 boxes under the map depicting the countries who have introduced meningitis A vaccine just illustrates some of the examples we can discuss and use at SAGE for decision making and in all our forums. This is, I think, one that you will be interested. We look also at the trends in expenditures in immunization programs because they could tell something about priority setting. Or they can tell you also that the country maybe did a big deal in the price of the vaccine, and then maybe this is why the costs are there. But it's important to monitor that and to see how much countries are investing in the program from their own resources. And finally, you will like my last slide. We also look at the broader impact in the community. So we consider the productivity gains, the community benefits, and the economic impacts. And Raymond now is going to talk about more in detail about how we assess these effects. So thank you very much.